Yes, this is Dr. Mark Pietropaoli again with Dr. Carl Calabrese, our Physical Therapy and Rehabilitation Director at Victory Sports Medicine and Orthopedics. And we've gotten through some of the preliminary parts of what a telehealth visit would be and how you want to set the room up, set yourself up. We've gotten through the history part. Now we're going to do the physical part. And that's the part that everybody thinks, oh, you can't do that with a telehealth visit, but we're going to show you that you can. Couple things to remember right off the get-go. We still like to have vital signs if we can have them, okay, just like we would in the office. So most people can give us their height, they can weigh themselves. So Carl, what's your height?
5'6" on a good day.
And then your weight?
171.
171. So it was 184 the last time that, so you're getting yourself into svelte shape there. It's good.
Going vegetarian helps. So.
And then a lot of patients have blood pressure cuffs at home. A lot of patients have smartwatches. So I'm surprised, actually myself, how many people can give me all their vitals. So if you have those help. I think that helps. Also, we can have patients, like if it's an upper extremity, Carl's a medical provider. He knows how to take his pulse, but most patients know how to take the pulse. Basically, you got your thumb here. You got this fat part at the bottom of your thumb. You just put two fingers right here at the base and you can feel your pulse. Almost everybody I've seen so far has been able to give me their pulse. And usually we just do 15 seconds and then multiply that times 4 and we're able to get their pulse. So Carl's gonna give us his pulse. He had, you know, if you have a smartwatch on, most people are able to give me it instantaneously, but you can just get it there. If we're doing an exam on a lower extremity, a lot of people, we can figure out how to get it on their feet. It's called their dorsalis pedis pulse. If you can't get it, you can always go with the neck right here. That's the easiest I found. So what do you have there, Carl?
15.
Okay, so yes, thank you. 15 times 4 is what? 60, right? So
Yeah.
we're good there. Then we start from the top. We just look at the patient. So you can see Carl's spaced far enough away. We're going to be seeing him for his shoulder. I'm not looking straight at his face. So he has the monitor far enough away. This is perfect. He even has an exam table, which most people don't have. But in any event, he's far enough away where I can see him. We can communicate. I can see he's in no distress. He appears healthy, well nourished. Those are things we usually look for right off the bat. So we can see how the patient's looking with a video visit, much better than a phone visit. He already gave me his pulses. There's other things we can do. He can show me close up his skin, press on it, take his finger off, and that'll show us what his capillary refill is like in a foot or something like that. If a patient doesn't know how to get their pulse, that's pretty easy to do. What I'll start with is we'll start from the top and work our way down. So we'll start with the neck. We're going to be seeing him for his shoulder, but a lot of times the neck can overlap some symptomatology into the shoulder and vice versa. So Carl, look all the way up and then all the way down, all the way to the right, all the way to the left. So that's tilting. Now rotate right, rotate left. Any pain or difficulty doing that? Nothing radiating into the shoulder. So it seems like he has full range of motion. Now I can't reach out and palpate or touch for areas of tenderness, but Carl can. So I tell the patient, hey, poke around everywhere. They know where their pain is. So a lot of times in the shoulder, where he's pointing right now, that's called the trapezius. A lot of patients will have pain and spasm in that area. And, what we can do is, do you mind taking your shirt off, Carl?
No, that's fine.
So usually, again, I would have the patient take their shirt off. If it's a man, if it's a female, we'll have them in a tank top. If it's a man, they want to be in a tank top, that's fine as well. But so the trapezius muscle there that he's touching, a lot of times that'll have some spasm in it. The patient will find that for us, but you're not noticing anything like that right now, correct?
Just a little bit more increased tone on the right.
On the right side.
On the left, but that was from working out. So.
Okay. So I can actually switch this. Last time it was mild spasm on the left. We'll switch it to mild spasm on the right. Is that accurate, would you say?
That is accurate, yep.
And in the interest of time, I'll change that later on. In any event, he has good motion. You can kind of push against your hand, front, back, sideways. You notice any difference in strength there on the neck area?
Oh, everything's good.
Everything's good. Obviously, his head didn't fall off, so visually he doesn't appear to have any instability there. Now, the same thing on the shoulders. I'm not noticing, I mean, maybe I am noticing a tiny bit of atrophy on the left compared to the right. What do you think, Carl? I mean, I can't, might be just the lighting, but.
I think it might be the lighting, but that delt does fatigue out a little quicker than.
So he might have a little bit of deltoid atrophy, a little bit smaller, but I can just observe him. He can turn around. We can have him bring his arms up above his head, make sure there's no winging of his scapula, which is his shoulder blade. That looks good, pretty symmetrical. You can turn back around again. Now, poke around on your shoulders, poke around anywhere on your upper extremities, and just find the spot that hurts. And patients are good. They'll find the spot that hurts a lot of times better than we will. So he's pointing posteriorly, and basically that's the same spot that he was tender the last time. How about on the AC joint, up on the top where that little bump is there? No, nothing.
Nope.
All right, good. So we have that. Now let's test strength. So we have to have the patient do this themselves. So usually what we'll do is I'll have them hold their arms up like this, okay? And this is the deltoid muscle we're going to test. And he's going to push down on one side, and then he's going to push on the other side. And they can tell me one side feels weaker than the other, and also if there's pain. So do you have any pain, or do you notice any weakness side to side?
Left side slightly diminished with some awareness of discomfort.
And if I'm in the office, a lot of times I'll have to back up so the patient can see what I'm doing too. I'm a little backed into a corner here, literally. But I'll tell them to. This is the supraspinatus, one of the rotator cuff muscles. So point your thumb down, push down with your other arm, and try to resist that, and do it with the other side. And then he'll be able to tell me if he has any weakness or pain. Patients are this is easy. They have no problem doing this. Any problems?
Discomfort with that, slightly weaker as well.
Okay. And now, again, usually I'd back up, but I have my arms at my side, and I'm going to push out. This is called external rotation, and they'll be able to let me know if there's any pain or weakness there.
That's fine.
Okay.
That's strong.
Good. And then we'll test the biceps and the triceps. So he's going from his side, he's going to pull in and then push out. Any difference side to side? I have them do both sides. They can tell me if they have pain, if they have any weakness, and patients will tell you. And then we'll keep going. Wrist extension. So bring your wrist back, push down, and then wrist flexion. I'll have them pull up, see if there's any difference there. I'll have them spread their fingers apart. This is called the interossei. It's the finger muscles in the hand. Okay? And then just stick a finger out and grip it real tight, and do it with the other side, and they can tell me if their grip strength is equal or not equal. And there's lots of other tests we can do as well. Those are all equal, Carl?
Yep.
Good. And we can kind of look at his muscle tone. It doesn't seem to be overly spasmed on anywhere or anything like that. But again, sometimes the patient can tell us if he said he felt a little increased tone in that one trapezius, but no place else in your arms there.
Nope.
Okay. Now let's test your range of motion. So bring your arms out to your side, bring them up above your head as far as you can go. So that's great. So that's called abduction, active abduction. Then we're going to do active forward flexion, straight ahead. Perfect. And then he's going to turn around and reach behind his back as far as he can go with his thumb up. And the bottom of the scapula, the shoulder blade, is T6, so he's about T5, and on the right, and then on the left. A little bit less, like you said, but throwers oftentimes have decreased internal rotation. Also, he has that problem in that left shoulder that we know about, so that is a little bit decreased. Now, there's certain stability tests that we can't do, so we're going to just defer those, but there's some other tests, special tests that we test for certain things that we can kind of modify. We can't do them exactly the same, but if I have him hold his arms up like this, and then kind of quickly go like that, and quickly go like that, that's a modified Hawkins impingement sign. And patients who have rotator cuff pain, they will not feel comfortable doing that. That'll hurt. We'll also do one to test his AC joint. So I tell them to straighten their elbow all the way, kind of bring it up like this, and then push hard with his left arm, push hard, and then do it with the opposite side. And do you feel any pain anywhere?
No pain with that.
Now, if his AC joint was bothering him, point to where that would hurt on that left side. It would right up there. He'd point there, and that test would be positive. There's another test called O'Brien's test. He has a labral tear. So if we have him reach across, point his thumb down, okay, and then push down with the thumb down, and then he's going to flip his palm up and push down. Do you notice any difference, Carl? Is there pain, first of all?
Thumb down, I do have pain. You can just get into that position.
Yep.
It's definitely harder to hold up versus the right as well.
And so the pain is where? On the surface, deep down, or put right back there?
Posterior, right in that spot where that labral tear.
So yeah, so we, in his case, we kind of know he has a labral tear, but I would say that's a positive test. There's another test we can do called Speed's test. To test his biceps, so he can reach out in front, push down with one, push down with the other. Usually, if the biceps was bothering him, it would hurt right in the front of the shoulder. You can point to where that is. Also, there's a thing called Popeye bicep sign. If that biceps tendon's torn, we can see that he would have a lump there, a defect and a lump, but we're not seeing that either. But there's a lot of testing that we can do that even though we don't have our hands on the patient can help us with. And then the rest of your upper extremities, can you straighten your elbows out all the way, Carl? Yep, and then bend them up, and then put them at your side. Go like, yep, palms up, palms down, so we can test that. We already saw his range of motion of his wrists, his fingers. So we've already seen a lot. We can't do reflexes. Some patients know how to do their own reflexes, or there's a health care provider or someone who knows how to do the reflexes on the patient. But in general, the only other thing, I like to do is I make them touch, feel around. Do they feel any numbness or tingling? A lot of times if someone has carpal tunnel syndrome, they'll point to their thumb, index, middle finger, right, Carl? These fingers here. Or if they have an ulnar nerve, the funny bone nerve, they'll point to these fingers. And they'll say, I have numbness or tingling here. So we're able to test that as well. Carl, any other, that's just kind of a overview of some of the majority of the tests that we do, but any other things you find helpful? Because I know you want to do more of the functional type of things.
Yeah, so a lot of times patients with shoulder issues, that repetitive movement or even that lifting, so I may put them in a position, put them in the kitchen and have them grab a plate that they report that that's one of their biggest problems, or dishes, etc., and then go through that. We'll use that as a baseline test, run through our exam and a treatment, and then use that as our reassessment. And that's a good way for us to ensure from a rehab standpoint that we're going in the right direction and we're on this thing. So making it functional, making it as close to what brought you to the office or remotely is kind of our goal.
All right, just one last thing. If you can put your shirt back on and stuff. I'm just going to flip the screen and I'm going to show you the x-rays and MRI. And I think since this was done back in December of 2018, I think we're gonna update this because we want to see if this cyst is getting any worse. You're a young guy, and we want to make sure this isn't getting any worse. So I'm going to flip the screen, so you can see, Carl. Can you see that?
Okay. Yeah, I can see that well.
This is called your glenohumeral joint. Not that you don't know that, but here's the ball, here's the socket. And this is the back part. Here's the front of the shoulder, here's the back. We're kind of looking straight down on it. And the bone should be white. And you see this kind of blacker area back here within the bone? That's the area where there's a cyst. And what happens is as the cartilage wears down, or as the labrum, which is the cartilage around the socket that kind of sticks out like that thing on a plunger that gives it a little bit more suction, a little more stability. If that tears or gets beat up, the fluid within your joint, we have lubricating fluid within our joint, that fluid can leak out and it can form a cyst that actually you can see over here. That white area right there is the cyst within the bone, and then there's some cyst also outside of the bone. So basically, the fluid from the joint is leaking into the bone, probably because there's a little arthritis in there where the cartilage is wearing down, and then also outside the joint. And that's right in the back of the shoulder where your pain is. We don't want that to be getting any worse. We don't want to talk too much about surgery, but that might be a possibility. But I think it's time to update this because it's been, year and a half or so and you're still having symptoms. So what do you think about that?
No, I agree. I think we just got to make sure it's not getting new.
Okay. So I think that pretty much ends the visit for today. I appreciate you did a great job, Carl, explaining things. Any other things you think we should let patients know to help with their telehealth visits, especially from a rehab standpoint?
I don't think so. I think we covered a lot of good stuff.
All right, thank you. And if you guys have any questions, you can go to our website, victorysportsmedicine.com. We'll be posting this video or parts of this video. We'll be having a lot more information on our website, our Instagram, our Facebook, LinkedIn. And also, if you want to call our office, you have any questions or want to make an appointment, 315-685-7544. Thank you very much and have a great day.